Nancy Davis all queued up, and she'll be starting here in a second. Let me handle a little bit of administrivia before we start. First off, today is a remarkable day for PLCs. There are at least 135 people who have signed up for today's PLC. Many of them are in teams, so there may be more than 135 sets of ears and eyes who are taking part today. But this is clearly the biggest PLC that we've ever had. If any of you are experiencing an echo, it may be because you have logged in simultaneously with the phone and with your computer. You may do better if you choose one or the other for your login. Also, let me remind you that in the fall, SACME will be having the conference in Baltimore on November 12th and 13th. Now is the time to start making your plans and registering for SACME's fall conference in Baltimore, November 12th and 13th at the Inner Harbor. We'd like to follow up with you by email after today's PLC. If you're willing to do that, we'll assume that you are, and there's nothing for you to do. However, if you are opposed to getting an email from us, please email me and opt out. And it's jack.balcourt@hsc.utah.edu. So moving on for today's PLC, we will be modeling some known approaches for increasing educational effectiveness. We're going to be using multiple sessions. We're going to be using reinforcement via the audience response system. This will be an opportunity for you to try and personalize what you've heard today by giving you an opportunity to apply, and we'll be following up with you on the follow-up survey to find out what has worked for you. For those who will be watching the archive version and who aren't here in person, that will be available on the SACME website, but please go ahead and do the exercise even though you're not viewing it live. So today's presentation is Effective Integration of Quality Improvement in CME CPD. It will be conducted by Dr. Nancy Davis, PhD Chair, Vice Chair of Professional Development and Practice-Based Learning, Department of Family and Community Medicine, University of Kansas School of Medicine at Wichita. So Nancy, over to you. What happened?
I think Nancy may be having an audio problem since we went live. Give me 1 minute to try to get her connected back in.
Thank you, Jim. So everybody, please stay tuned.
Are you able to hear me now, Jack?
Nancy, yes, I am. Thank you.
Okay, so you haven't heard me from the beginning?
No, it was total silence, so
Okay.
I think it's time to start all over again.
All right, so sorry, apologies everyone, had a little technical glitch there. So again, I'm very pleased to be here this afternoon and very pleased with the response to this webinar. I think it speaks to the interest in this topic of SACME members, and I'm very pleased to have you all here. This session is one thing that we're doing in response to the very rigorous discussion we had on the listserv a couple of months ago about integrating quality improvement and maintenance of certification, and we'll say a little bit more about that later in the presentation. So why don't we get started? Oh, and one thing to warn you in advance, we're going to be doing some audience response polling here. So we'll cross our fingers with the technology, but really encourage you to participate so that we can have some discussion based on your responses to some of the questions I posed today. So just quickly looking at the objectives for this afternoon to describe healthcare quality improvement measurement principles and processes. So we'll be looking at some of those basic principles and how that works in terms of quality improvement. Utilizing performance measurement as needs assessment for CME. Again, we're very interested in those practice gaps, and this can be a means for us to identify those. Align performance improvement and continuing education with maintenance of certification. We'll be talking about that. And then finally, for you to participate meaningfully in this session. So I really encourage you to do that. I know it's a little awkward with the webinar technology. So let's start out with a question. Jack, this is our first question.
Okay, so the first question is, quality improvement is important to CME CPD because one possibility, it's now part of CME accreditation. Another possibility, it helps assess the needs of our learners. Another possibility is it improves patient care, a basic tenet of CME CPD. Another possibility is 1 in 3, and another is all of the above. So please vote now. The voting will take place for about the next 15 seconds, so please vote now. We're going to close the poll in about 5 seconds. Okay, Jim, can you close the poll? And we'll see what the results are. Okay, so the results show that the big winner was all of the above. 86% said all of the above, and then there were a few who said 1 in 3 only, and a small number of people said it improves patient care, a basic tenet of CPD, and 1%, a small number, said it's now part of CME accreditation. So it looks like there was a strong opinion that it was all of the above, and that it helps assess the needs of our learners. So I'd like to get some input from those of you who did the voting. Would somebody who voted for, why don't we just take who voted for all of the above, raise their hand and tell us why you selected that. Jim, I can't see who has raised their hand. Has anyone raised their hand?
I don't believe we have any hands raised yet.
Yeah, Jack, maybe we'll just move on to the next one, because that's obviously that's what I was going for there.
Okay.
I think sometimes we don't always think about using performance measurement as needs assessment, but certainly it can be very effective in assessing those practice gaps. So I think we'll move on, and we've got another question. So, and this one's a little bit different because you get to choose all that apply. So the question, which are the characteristics of quality improvement? So just to have us have a feel for what those characteristics are, and you can choose as many of these as you like.
Okay, so the polls are open. Please choose between evidence-based medicine, consistent practice, measuring clinical care, adherence to core measures, provider payment, and of course you can do more than one. Please vote now. Poll will be open for another 5 seconds. Okay, close the polls. Wow, we had a lot of homogeneity, that all of these responses were about in the same category, that people thought evidence-based medicine, consistent practice, measuring care, adherence to core measures were all about the same, and a few less said that provider payment based on meeting measures was one of the characteristics, but it still was more than half of our group which chose that.
Right,
So,
good.
Nancy?
Yeah, very, very interesting, and I think one could certainly argue that each of these is a characteristic of quality improvement in healthcare today. Even provider payment, because we're seeing a lot more provider payment being based on adhering to evidence-based measures. So just a word about the evolution of quality improvement. For those of us that were around in the 1970s in healthcare, really quality was all about quality assurance. So it was very event-driven. It was all about compliance. There were these things called utilization review committees in hospitals. It was very regulatory and retrospective. So those utilization review folks were looking at charts to see if folks were adhering to standard of care. And it could be quite punitive against an individual. So it was not looking at the systems issues or the processes that were in place. It was really about chart review and looking at whether or not individual physicians were adhering to standards of care. So then we evolved to the 2000s, where all of the literature was coming out about healthcare quality, and you remember the quality chasm and the statistics that people were being killed in hospitals at great rates because of quality and quality deficiencies and errors. So there was a big movement toward quality improvement at that time. It was about, again, accreditation driven. It was population-based, though, much more process-oriented and more organizational focused, as opposed to being that very individual focus that we saw in quality assurance. And then if you look forward to where we are today, we're really talking about continuous quality improvement. So it's much more information-driven, looking at outcomes, that consumer focus. So again, we're really bringing the patient into the mix and at the forefront much more than previously focusing on the individual clinician. A lot more around innovation and sharing of best practices. So I think it was kind of interesting, this article from Mary Delansky and her colleagues about how quality has really evolved over the last many years. So if we think about performance improvement, a lot of folks use the term performance improvement and quality improvement interchangeably, and I think that works usually. How I like to think about it is that performance improvement is a part of quality improvement. Quality is kind of that overarching concept, and if we improve performance, then we ultimately improve the quality of our patient care delivery. So if we think about the performance improvement process, start with identifying evidence-based measures. So again, a key phrase there is evidence-based. We're going to look at those measures that actually have some evidence behind them. Collecting data to assess current practice, so identifying those practice gaps. And then implementing interventions for improvement. I underline that because usually it takes more than one intervention. It often takes a number of interventions to make change and improvement happen. Then remeasurement to assess improvement or not, and then reflect on that change or the lack of change, and finally spread and sustain that change, that improvement. So I think that's often where we drop the ball, is in terms of spread and sustainability, because often quality improvement projects tend to be kind of one-off projects and really aren't able to spread and sustain. So while all this quality improvement was going on, Performance Improvement CME was born. And that happened as a result of a very smart man that many of us know, Dennis Wentz, who was at the AMA, and said, you know, we keep hearing all this rhetoric about CME not working and not being effective. and yet there's all this quality improvement going on in practice that really is effective and really is improving practice. So why not give CME credit for something we know docs are doing more and more, and that we know actually makes a change in practice? Jack, could I get a sound check and just see if the echo is better now?
Okay, at least for me, I hear no echo.
Okay, okay, good. It went away from me too, so I just want to make sure we were sounding better. Performance improvement CME was a mechanism to give credit for quality improvement that was already going on in practice. So let's have a little assessment of our learners here and do another little polling question. And all of the following are true of performance improvement CME, except one of these is not true.
Okay, so now is the time to vote. Select only one. Five more seconds. Okay, polls are closed.
All right. Interesting spread there. So 60% of you said that number 2 is not true. Certified CME activity is required to improve practice. And that would be the correct answer, or at least one I was going for. And some of you had some hesitation about when PICME was launched, and in fact it was launched in 2005. So a word about that coming up as well. So a little introduction to PICME, and before we get into the semantics of that and the way credit goes with PICME, let's talk a little bit more about quality improvement and what it takes to do that improvement that we talked about earlier. So first, to think about measures and what are measures. If you haven't been involved in quality improvement, that may be a bit of a foreign concept, or even if you are familiar with quality, you might have a little trouble distinguishing the types of measures. So I'm just focusing on the 2 major ones here. There are other kinds of measures, but if you know these 2, you'll go a long way in terms of integrating quality into your educational efforts. So the first are process measures, and these are things I like to define as being in the clinician's control. So an example of that might be ordering that hemoglobin A1C to manage your patients with diabetes. So the clinician has the control of ordering that test. Now we assume that these things that the clinician does will affect the outcome. And an outcomes measure is that actual patient outcome. Now there are a lot of variables with that are often outside of the clinician's control. So the example of an outcomes measure here is maintaining that hemoglobin A1C value at X, whatever your measure designates as that value. So the idea is that even though you might prescribe the medication, prescribe the diet, the exercise regimen, all those things to your patient, there still may be reasons that those hemoglobin A1C values are not where they should be. And some of those variables are under the patient's control. Okay, so we got process measures and outcomes measures. So how do you know if you're okay? Well, there's a way to calculate compliance with the measure, and that requires a denominator and a numerator. The denominator part of the equation is the number of patients in the practice who are eligible for the event or the treatment that's being measured. The numerator then is the number of patients who receive the appropriate care or reach the appropriate outcome. So let's look at our diabetes example again. The denominator would be the number of patients in our practice with a diagnosis of diabetes, a number of adult patients in the practice with a diagnosis of diabetes. The numerator then for the process measure would be the number of adult patients with a diagnosis of diabetes who have hemoglobin A1C ordered appropriately. Or if we're looking at the outcomes measure, it would be the number of adult patients with a diagnosis of diabetes who have a hemoglobin A1C value of X, whatever that determined amount is. So you see, you can do this calculation, and once you've done that, you come up with the percentage of adherence to that measure in your practice. So I put this in for Jack. There's a fine line between a numerator and a denominator, and only a fraction of you will understand this. So there's my little attempt at measure levity. So let's move on to the next question. So where do measures come from? I've defined types of measures and given you some examples. So where do these measures come from that docs are trying to adhere to? I've given you a list here, and one of these is not a source of performance measures. Looks like the poll is open.
The poll is open. Please vote. Another 5 seconds. Okay, the polls are closed.
So it looks like we've got some spread on this one, Jack.
Yes, so half said medical specialty societies did not develop measures, and there was a close clustering of the remaining three, Nancy.
Right, right. So this was a little tricky if you're not really involved in this kind of work. So the correct answer here, the exception is number 3, the National Quality Forum. So the AFA Physician Consortium for Performance Improvement, PCPI, is really quite a major developer of performance measures. They are a consortium, just like this says, of a lot of different specialties. A lot of specialty societies belong to the consortium. A lot of different specialists from various disciplines come together and determine, first of all, the priorities for what new measures should be developed, and then come to consensus on what those measures should be based on the best available current evidence. The National Committee for Quality Assurance, NCQA, develops measures primarily for health plans. And medical specialty societies do, in fact, develop a number of measures for their individual specialties. Now, oftentimes they develop clinical guidelines, and from those guidelines, measures are derived. So actually developing those evidence-based measures is another step after the guidelines. The National Quality Forum, then, is a group that endorses measures. So they have a group of experts that comes together and looks at the measures developed by these various other entities and decides which ones should be endorsed. And then various agencies like CMS, for example, decide they want to use those endorsed measures as a part of their payment plans, for example. So it's really quite a complex process and a complex entity that goes on in our healthcare system in terms of developing, endorsing, and actually implementing these measures. So moving on, we need to look at data sources in order, again, to calculate whether we're in compliance with measures. We need to collect data in the practice to look at whether or not we are being compliant with measures. And data can come from a number of sources. Some examples are here. Clinical data includes things like patient records, and that could be paper records or it could be electronic health records. But the idea is that the data would be extracted from those records in some way, either manually, which obviously would have to be in the case of paper records, but even a lot of manual extraction has to go on with electronic medical records because often the data is not collected in the record in a way that you need to assess the practice to a certain measure. There are surveillance systems that sit on top of electronic medical records and help to pull data based on the type of data that's needed to assess the measures. Administrative data then is what we call claims data. It comes from payers. And administrative data would only be good for those process measures, remember. So in our hemoglobin A1C example, we would know if that was being done in the practice based on billing. We assume if it was done, it was billed. So you could pull those data out from the claims data. Backing up to clinical data for just a minute, you could measure both process and patient outcomes data from the patient record. Obviously, you should have a record that the test was ordered, and then you would have a record of the value once it came back. And then finally, patient survey data is gaining more and more popularity in hospitals and outpatient settings. Patient data can be good for both process and outcomes kind of measurement, but you have to remember that it's self-reported. So depending on how really reliable you need those data to be, patient self-report may not be the best source of data. So this just gives you some examples of how data is being collected. I'm going to pause just a minute here and see if there are specific questions. And actually, I see a question here, Jack, about would all of the measure sources listed here be nationally endorsed measures? So I think the question is, would the measures from those organizations that I listed be endorsed? They would only be endorsed if they were endorsed by the National Quality Forum. So just because they're developed by a specific entity does not necessarily mean that they would be endorsed by the NQF. They have to go through that review process, which there's been a lot of criticism about because that process tends to take a long time. And obviously measure developers would like to have them endorsed as quickly as possible. Are there other questions that can be typed into the chat box, or?
Nancy, there's one, someone says, question, how would you incorporate balancing measures into PI/CME QI? Or would you even recommend would you recommend them at all? So I wonder what you're talking about with balancing measures.
Yeah, and balancing measures gets probably more complicated than I'm qualified to describe. But balancing measures are when you've got multiple morbidities and patients may not adhere to a specific measure because they have other things going on that contradict those measures. So it does get very complex, and I wouldn't say that they shouldn't be included in PI/CME, but I will say it does make it more complicated. So as I will say about everything that you're doing with PI/CME, you really need to engage content experts. So whoever the clinician experts are in that particular area, and get some quality consultation from some quality professionals so you know how to, first of all, collect and then analyze those data.
Nancy, there are no other questions that have been typed in.
Okay, let's move on then. So we've talked about measures and we've talked about data, and that all adds up to assessment. So we're done, right? We've got our data. We've done our assessment. Well, not quite. So now we're getting to the hard part. And I will say that maybe a decade ago, a lot of quality improvement did kind of stop there. It stopped with assessment. And the improvement part is really the hard part. So how do you know what to do? You've identified your practice gaps and the measures that you're concerned with. So how do we know what to do for the improvement? Well, here's where I put in my caution for the CME CPD folks. If all you have is a hammer, everything looks like a nail. And what I mean by that is that oftentimes we in CME try to solve everything with education. And this became very apparent with the initial PI/CME activities, and especially those that were going to certifying boards to serve as maintenance of certification part 4. It was very evident, those activities that had been developed in CME offices, because they focused on education as the intervention for improvement. And we just have to remember that often it's not that our clinicians don't know better, it's that they don't do better, and often for good reason. There are a lot of systems issues. I'm sure you've heard that before. So just to keep this in mind, that while education is important, and it may actually be one of your interventions, it probably is not going to be the only intervention that will lead to the change that you want. So you're probably going to need some quality improvement tools. And in this short time today, I just wanted to share a few of the more common ones and tell you where they come into play, and then have you think about how you might want to use them, and even more importantly, how you might want to collaborate with the quality experts in your organization to really help you to implement these. So root cause analysis, there's a very helpful tool that's often used called 5 whys, and it is exactly what it sounds like. So when you identify a problem, you ask, why is this happening? And once you've answered that, then you say, well, why is that happening? And just keep going down those layers until you peeled away that onion and try to get at that root cause analysis to identify your practice gap. Process maps can be really helpful to identify what's really happening. So if you can think about what's in play here, how is the system working, how is this environment working, and really map that out, it can really help you to understand what's going on. One of my favorite stories came from Eric Holmbo, who many of you may know or have at least read his work. When he was in practice, they had an issue with the immunization rates. They just weren't giving the immunizations appropriately that they knew they should be doing. Well, when they did the process map and they actually looked at what was happening in their practice, they realized the informed consent forms were in one place, the vaccine was in another place, the syringes and other supplies were in another place, and so it was just too much of a challenge for the staff to pull everything together and actually make the immunization happen. So once they figured that out and they were able to pull all of the supplies and materials together, their immunization rate went up. So sometimes it's just a very simple thing like that. And again, it wasn't because the clinicians didn't know who should be getting immunizations or why. It was really a systems problem. The fishbone diagram is used for cause and effect. So if you've ever diagrammed sentences, we were doing that back in grade school, it's kind of the same concept where you're identifying the categories of the process and putting them into a good diagram that will help you sort out, again, what's happening to create this practice gap. And then finally, run charts to analyze performance over time. You want to look at trends. You want to see how things are changing, so you need some way to look at data over time. So that's what run charts are. So if nothing else, I hope this exposes you to some of the language of the tools of quality improvement. And again, you'll need some practice and some instruction to use these, and I can't emphasize enough working with the quality improvement folks to make these happen. So back to PI-CME, and specifically looking at the credit for PI-CME. So there are 3 stages for identifying that evidence-based measure and assessing the practice. The intervention, and again, my caveat to think beyond education, think about systems and processes. And then remeasurement, documenting the improvement or not, and reflecting on what happened with the intervention and the change. So 5 CME credits for each stage, 20 for completing the whole cycle. Now, the good news is that the AMA PRA, the AAFP, and the AOA credit systems all use the same formula for PI-CME credit. We launched that in January of 2005. I had the privilege of being at AAFP and working with the folks at AMA to develop this, and it was really quite a fascinating process. And those 20 credits are quite arbitrary, but we decided that that would be a significant chunk of physicians' annual requirement for CME credit. And so we thought it would give it really the reward that it deserved for a lot of work. Obviously, we couldn't use a time-based credit for this because it just involves too much time to do these projects. So that's how PI-CME credit sorted out. And again, we launched in 2005. That's been over a decade now. So what's been the impact? It's been pretty sad. So looking at the ACCME annual report that just came out last month with the 2014 data, PI-CME accounted for 0.3% of the total CME activities. It's not 3%, it's 0.3%, only 470 activities. Now, I wonder if there is some underreporting here. I know when I talk to folks, I hear CME providers doing things that include a quality kind of process and include that measurement and intervention and remeasurement, but they're not giving PI CME credit for it for whatever reason. So I think there may be some underreporting here, but the reality is it just has not become a big part of the overall delivery of CME. The largest providers have always been hospitals, and that makes sense because that's where the quality professionals are for the most part. So it's easier to have that linkage between the quality and the education. Specialty societies have traditionally, since the beginning of PICME, have had significant numbers. And only in this last year did we really see medical schools coming up. They were almost equal with specialty societies in the latest annual report. So it's been very slow coming, and there are multiple reasons for that. So let me get some feedback from you. You may be among the CME providers that are doing PICME or not for one of these reasons. So please vote now and share with us which you think the top 3 barriers are to providing PICME.
Okay, vote now. The activity takes too long. There's a lack of expertise, a lack of perceived value, difficult to access data, lack of access. Vote now. Another 5 seconds. Okay, polls are closed.
Yeah, it's an interesting spread there. I mean, really pretty equal. And obviously, there's no right answer here. I would say all of these are barriers. And it may just depend on your circumstance, your situation, as to which ones are the worst or the most difficult for you to overcome. The activity does take a long time to complete for the physician, so they have to do a lot of work. It's certainly more work than sitting in a lecture or watching a webinar or something online. So it really does take some dedicated time. The lack of expertise by CME CPD providers has been a problem, and we knew it would be because we didn't have training and background in this quality stuff. So it's taken some time to really get it introduced to the CME side. And conversely, I think it's been difficult for the quality folks to understand the value and the role of education in quality improvement. You know, if CME folks see everything as an educational need, quality folks see everything as a process improvement need. So there definitely has to be some coming together on both sides to make this effective. Lack of perceived value by participants has been a genuine problem. So if you combine it taking too long and then lack of value, perceived value, then you've got something folks don't want to participate in. And I think that's been a challenge and the reason we're seeing those numbers so low. Our constituents just don't see the value in it and don't recognize it as a way to get CME credit. It's difficult to access data. We hear this time and time again, even in your own organization. I'm sure many of you have experienced this, that the quality folks don't want to give up the data to the education side. So it's difficult to get to those data, to use them as needs assessment even, or certainly to identify specific gaps in specific practices. And then lack of access to QI professionals for help. They are overburdened with the work, their daily work, and again, they don't recognize the role they can play, and so that's been a real challenge. So all of these have been barriers that we've been working hard to overcome, and some folks are doing well with it, and others are still struggling. So there needs to be a practice-based value. It needs to be integrated into practice. I think one of the challenges and barriers has been that it does feel like a remote kind of one-off thing to do. And feels like one more thing to do for the clinician. So we're trying slowly but surely to have this to feel like a part of practice. So every day a clinician needs to think about what are the practice gaps here, what are the data I could be collecting and should be collecting to improve. And there must be perceived value. So there's lots of access to CME credit. So doing extra work for something you don't really see as important to your practice, CME credit is not going to be that incentive to make it happen. I think we've learned that for sure in the last 10 years. So we've got a new carrot or stick, depending on how you want to look at it, and that's maintenance of certification, and specifically MOC Part 4, around performance improvement in practice. So the American Board of Medical Specialties maintenance of certification, Part 4, is that improvement in practice component of MOC. I really think this is the new value add to CME CPD. If we can help folks meet this requirement, and of course, Part 2, the self-assessment and lifelong learning, has been quite apparent that CME should be involved in that, but maybe not quite so apparent for Part 4. MOC credit is more difficult to acquire than CME credit, thus more valuable. So again, that value add, if CME can provide this to our docs, then certainly will be seen as a value add. Maintenance of certification, Part 4 in primary care, the primary care board, family medicine, internal medicine, and pediatrics, was developed at the same time as PICME. So that was really quite fortuitous because it allowed us to come up with that process improvement process that is the same for PICME and for MOC Part 4. So certainly, we're all speaking the same language and trying to get the same end result. So speaking of practice-based value, this is our friend David Price. Those of us in SACME know David well, and I think he's on the call today, so he can correct me if I'm wrong about any of this. But David is now the director of the ABMS Multi-Specialty Portfolio Approval Program. And this, I believe, has been a wonderful improvement to the whole MOC process for Part 4. So the idea that an organization can become an approved sponsor and then review and approve their quality activities so that their physicians who are diplomates of the various boards can get their MOC credit by participating in something that they're already doing in their practice at home. So this is definitely a value add. Many CME offices are serving as the administrators of the portfolio program in their organizations. But even if the portfolio program isn't coming out of the CME office, certainly the CME office should be involved and be participating in this because the PICME credit can go right along with the MOC credit for these activities. So a little bit more about you now. We've talked about barriers that you may be perceiving. So tell us about yourself and what your current status. Are you doing no PICME at this time? Are you doing PICME but not approved for MOC Part 4? You're doing PICME and at least some of it is approved for MOC credit. Or you're doing MOC Part 4 activities but no PICME credit. So tell us about your status.
Vote now. Polls are open. Five more seconds. Okay, polls are closing. Nancy, it looks like about 41% people are doing no PICME at this time. About 38% are doing some PICME that is MOC approved. Some are doing PICME which is not approved, and some are doing MOC but with CME credit.
Great. Well, this is encouraging. I'm really pleased to see that percentage of folks doing PI-CME with at least some of it being approved for MOC Part 4. And I think those numbers will continue to rise. I think the portfolio program will help that a lot too. And for those of you that are not doing PI-CME at this point, I hope this session and others will help to encourage you and help you to make that decision about whether you want to start providing some PI-CME, or if you're thinking about plunging into the quality with or without the formal PI-CME at this point. I think that's really encouraging. So the bottom line is working toward harmonization, because we can look at PI-CME and MOC as just kind of one more thing to do. And clinicians are really getting hit hard with a lot of requirements these days. So you're no doubt familiar with meaningful use in health information technology and the requirements now for that. So if we can collect the data for performance improvement and help meet those requirements for meaningful use, if we can align our PI with ongoing professional performance evaluation, use PTRS and other measures used for payment. So for example, if you're thinking of creating PI-CME activities and you can use those measures that are already being used for payment, either by Medicare or for other private payers, using those measures will be an added value for your clinician users. Providing PI-CME credit and providing MOC credit. So if you can think about performance improvement as a way, obviously, to improve patient care, but then meet all of these other requirements at the same time, it will really help to alleviate the burden of those physicians who have all of these requirements. So I provided a very short reading list here. But some things that I found helpful in terms of learning more about quality improvement. You can't just jump into the quality literature when you don't have any background. So I found these resources helpful, and especially some of the articles that are listed there talk specifically about integrating quality improvement with CME and with maintenance of certification. So I think those things could be very useful, especially if you're just starting to dip your toes into this whole process. So I'm going to stop there and see if we have questions. I see one. Oh, I'm sorry. I forgot my last question, Jack.
Okay, so why don't we do that first?
All right. So this is about an action plan and what you're going to do next. As a result of this. We talked about a lot of different things here. So you're going to look more closely at, and you can choose all of these again, look more closely at the PI-CME requirements, meet with the QI professionals in your organization, research relevant clinical measures, those that are important to the docs that you serve, explore options for clinical data collection, design a timed strategy for performance-based CME in your organization, or something else that you can type into the chat box.
Okay, please vote now. Another 5 seconds, then polls will close. Polls are closed.
All right, good. Oh, we're happy you said you're going to meet with your QI professionals. Good. Right. Got one message through loud and clear there. I think that's really important. And then several of you said really all of the other things. So it sounds like the folks on this call are motivated and ready to start taking some action. I love those of you that said that you're going to develop a time strategy for performance-based CME in your organization. That's the only way you can make it happen, is to sit down and come up with a strategy to make it happen. So hopefully what we've talked about here today will help. Okay, now we'll take some questions, and I see, I can see one. I may have to figure out how to scroll here. Let me answer the one I see, and then we'll see if we can get to the others. Is it possible to double dip and receive PI, CME, and MOC Part 4 credit for a particular QI project? Not only is it possible, it is desirable. So yes, please. You can, if you're not a portfolio sponsor, you can still apply to individual boards. If you have a PI-CME activity that you would like to have considered for MLC Part 4 credit, you can make an application to a specific board. And of course, if you are a portfolio sponsor, then those QI activities that you've approved for MOC credit certainly can and should have, in my opinion, PI-CME credit. So yeah, that's the answer.
So Nancy, there was another question that asked for clarification. Can QI educational interventions address both types of measures, that is, process and outcomes?
Yes, certainly they can. And the outcomes are just a little bit more difficult to really determine cause and effect. So to use my simple diabetes example again, you might set up a PI-CME activity to, and the measures would be ordering that hemoglobin A1C, doing a foot exam, for example, ordering an eye exam. Those are the things that you would include in your PI-CME activity. And then if you want to look at the outcomes measures, you certainly can do that. But as I said, you're going to have a little bit more trouble connecting to those patient outcomes. So, and it takes a little more to get those data. So you'd have to do those chart reviews to look at the actual patient outcomes. And you may need to look at cause and effect. Well, if we're not at that patient outcome, why is that? Is it because we're not doing the process measures, we're not ordering the hemoglobin A1C or the appropriate medication, or are there patient issues that we need to address in a different way? So yeah, you certainly can. It's, the process ones are easier, I'll just tell you that.
So Nancy, there's a couple people who asked questions about the AMA's calculation for credit for PI-CME, and the question is, I feel that I'm always getting confused. If someone only participates in stage B and stage C, but not in stage A, how do you calculate the credits? Can they still get credit, 5 credits each for stage B and stage C?
Yeah, so somebody else may need to give a more authoritative answer on this than I can. When we set up the process, you could give credit for each of the stages separately. I understand there's been some controversy about that, and Jack, do you know, or does someone on the call know what the AMA PRA position is now in terms of splitting the credit?
Could somebody raise their hand if they have the definitive answer? Jim, do you see anybody who's raised a hand? I can't see that information.
No hands raised.
So probably the smartest thing to do would be to contact the AMA, because they own the credit system, and get a clarification. And in fact, when you do that, why don't you put it up on the SACP listserv so that all of us could get that information?
Yeah, good. I've been out of the credit business for long enough that I just would hate to give misinformation.
So there's
Jack, we do have a Kristen. Let me unmute her. Okay, Kristen, you should be live.
My understanding is that they can receive 5 credits for each individual stage, but they only get the full 20 credits when they complete each stage in the order of stage A, stage B, stage C.
Good, thanks for that feedback. And I think we will make sure that we get that answer from AMA PRA so that everybody has their language.
So Nancy, there's another question. Someone asked, why do you say that PI and QI can usually be used interchangeably? Seems that they're very different since accreditors have established formal criteria for PI-CME, but QI-CME is not yet to be defined formally. So what do you think about as a distinction between PI and QI, and can they be used interchangeably?
Yeah, so in terms of credit, you're right, there is only PI CME that provides CME credit. I was just thinking in more general terms that we often hear the term quality improvement and performance improvement used interchangeably, and just in terms of that improvement. But you're right, for credit, there's only PI CME credit, but it certainly uses quality improvement principles in the design.
So Nancy, there's another question asking for your opinion. What's your take on ABIM's recent decision to change the Part 4 practice assessment component from required to optional? Do you think this will be temporary or what? Do you have an opinion?
Yeah, I think in light of a lot of negative response to maintenance of certification in general, the ABIM decided to just reassess their process and look at the data. ABIM has done a lot of research around maintenance of certification. A lot of other organizations have as well, but ABIM has really done a lot of research, and they've really been trying to respond to the concerns of their diplomates. So they've put things on hold right now while they continue to do that assessment and determine what the best approach is to maintenance certification. So I think a lot of folks are waiting to see what the outcome of that is and whether other boards will follow suit. So I think it was a thoughtful response on their part to just put things on hold for right now, take a look at it, and then determine how it'll go. I don't think it'll be on hold forever. I think there will be some resolution and some way of going forward with MOC. Okay.
Another question, Nancy, it has to do with the practicality of fitting in with ACCME requirements, such as for disclosure. How does one do disclosure when it doesn't seem to apply to MOC Part 4?
Yeah, that's probably a question for ACCME. So I'll just concede this much. PI-CME does not fit the mold of more traditional CME, and so there have been a lot of challenges with it, not the least of which was just assigning the number of credits. So it doesn't fit the mold, and I know that's been a barrier in just deciding how those other kinds of requirements fit with PI-CME. So you're right, it's difficult.
We have
Mauricio has his hand raised. Would you like to call on him?
So Al, yes, please give us the story.
The definitive answer here.
Hi, great job, Nancy. Great job, Jack. Yeah, I'm sorry. I had typed the answer into the box to send to staff, but I guess I probably didn't do it correctly. You have to start with stage A, and it makes sense if you think about it, because if you don't start with stage A for PI-CME to get credit, what are you improving? You don't know what your baseline was. So you can get 5 credits if you did stage A, 10 credits if you did A and B, and 20 if you did all 3, but you cannot get anything unless you start with stage A.
Thanks, Al.
Sure, anytime.
So I think our time is running out, Jack, so I will pause and just thank you all for a great session. Thanks for your thoughtful questions.
Good. Well, thank you very much. The slides will be up on the SACME website. We'll be sending out a follow-up survey. And finally, again, reminding you that it's put on your calendar the SACME Fall Conference in Baltimore, November 12th to the 13th. So Nancy, thank you very much. Thank you for all your work in putting together this fine presentation. There'll be more on the topic to follow. Jim, as usual, thank you for all your hard work for making this happen. So with that, let me close today's PLC. Thank you very much for attending.